Hi, my name is Ouaknine. Welcome to this video presentation. Breastfeeding is universally accepted as the best method of feeding infants. Ensuring the preterm infant's ability to breastfeed is that much more important. Benefits to feeding preterm infants breast milk include reduced incidence of infection, reduced incidence of necrotizing enterocolitis, improved feeding tolerance, enhanced neurodevelopment, and decreased number of hospital readmissions. In this video, I will apply the situated clinical decision-making framework within the context of breastfeeding the preterm infant with inverted or flat nipples to explain how we can use knowledge, cues, judgment, decisions, and evaluation to help the preterm infant successfully breastfeed on a breast with inverted or flat nipples. Let's discuss the preterm infant. The preterm infant is prone to instability of the autonomic system, demonstrated by tachypnea, pallor, mottling, apnea, bradycardia, and O2 desaturation. Premature infants decompensate more quickly than term infants. Premature infants are more disorganized in their sleep-wake states, and they spend more time in transitional and active states and less time in alert states than full-term infants. Preterm infants have difficulty effectively organizing their sucking, swallowing, and breathing than full-term infants, all affecting their ability to breastfeed well. The behavioral cues of the preterm infants may be more subtle and more difficult to interpret than that of the full-term babies. Due to a lack of energy to display more obvious behavior responses, this makes it difficult to feed them on demand. What about the nipple appearance? There are a variety of nipple appearances and inversions. Neither visual assessment nor self-reporting of flat nipples are adequate tools to determine nipple protractility. 10% of women are said to have flat or inverted nipples, and most will be able to breastfeed successfully. The best test for nipple protractility is done by the baby at the mother's breast. If the baby can breastfeed well, there is no need for further intervention. We can also use the nipple pinch test to clarify if a nipple is flat or inverted. By gently compressing the areola about 1 inch from the base of the nipple, placing the thumb on one side of the areola and the index finger on the opposite side, if the nipple does not protrude, it is truly inverted. Some causes for inverted or flat nipples would be an areola that is not elastic, an engorged areola that may flatten a normally protruding nipple, adhesions that connect the nipple to the inner breast tissue, breast surgery, or less dense connective tissue located beneath the nipple. It's important not to make statements to the mothers regarding the suitability of their nipples for breastfeeding, as they may negatively affect her confidence level in her ability to breastfeed. Both the preterm infant and mothers with inverted or flat nipples pertain to separate breastfeeding challenges that can be overcome with good technique and help. The most important thing is to be able to recognize the cues that would lead us to understand that there is a challenge present so that we can intervene. For the preterm infant, it's important to recognize the signs of breastfeeding readiness, which may typically be anywhere from 28 to 32 weeks gestation, although maturity is more important than gestational age. The infant should be physiologically stable to initiate breastfeeding, remain stable throughout the feed and after the feed. Should they fail at this, they may not be ready for breastfeeding. If breastfeeding is initiated and the baby is unable to latch, the mother's breast should be assessed for flat or inverted nipples as potential causes. Given the challenges of breastfeeding a preterm infant with inverted nipples, the priority should be to feed the infant by supplementation, move the milk by pumping, and help the dyad learn to breastfeed using the 3 E's: early, effective, exclusive, all to help getting the infant feeding and mother's milk producing. Beginning to breastfeed as early as the preterm infant is able to is important. Effective breastfeeding, or working at gaining a good latch, is important to maintain good milk supply and allow the baby to gain more from each feed. It is recommended that feeds contain exclusive breast milk without the addition of formula whenever possible. There are a variety of steps we can take to gain success at breastfeeding even before the preterm infant is ready to attempt at feeds at the breast. Any mother of a preterm infant should be shown how to pump with a hospital-grade pump at a frequency of every 2 to 3 hours, beginning within the first 6 hours of life, including nighttime, as prolactin levels are at their highest at night. Pumping will also encourage a flat nipple to protrude. Mothers of preterm infants should be counseled on how to safely store their milk so that it can be fed to the infant until they're breastfeeding exclusively at the breast. Parents should be encouraged to participate in skin-to-skin cuddling of their infant in the NICU, allowing the infant to enjoy the sensory stimuli of the breast, facilitating increased milk supply. Giving gavage feedings while skin to skin may help move the infant toward a mother's breast, which may lead to the preterm infant nuzzling or licking the nipple in the early stages. This is a positive step towards breastfeeding success for a preterm infant. Allowing preterm infants to use non-nutritive sucking, or NNS, which refers to the infant performing a sucking activity with the mouth without gaining any nutrition, as in on a pacifier or empty breast, helps to increase periods of wakefulness, increases levels of oxygenation, and accelerates the maturation of the sucking reflex, which leads to the better breastfeeding technique and earlier discharge. If a challenge presents itself upon trying to breastfeed, we can assess a mother's nipples. And if the mother has been assessed to have flat or inverted nipples, there are some easy steps we can include to help get the process started and have the nipple protrude somewhat before the feed. Prior to starting the feed, we can suggest that the mother try to express some breast milk to soften the areola. She may wish to apply wet or dry heat in order to express some of her breast milk. Sometimes the nipple can be stimulated to protrude with touch by a partner or by short use of a cold cloth. It is essential to avoid overexposure to cold at the breast, as it may inhibit the letdown reflex. The use of a good electric pump prior to a feed is a common way to help draw out the nipple. In most cases, the pump is enough to help protrude the nipple to begin the feed. However, in some cases, positive gentle pressure is applied by placing the fingertips around the base of the nipple to create a ring of dimples. This can temporarily reduce the swelling and permit latching. This is called reverse pressure softening. The use of nipple extractors are sometimes useful as well in helping the nipple to protrude, shaping the breast to create more definition to the nipple and compress her breast and areola between two fingers and the thumb to provide as much nipple as possible also may help the preterm infant to latch to a flat or inverted nipple. This is sometimes referred to as a nipple sandwich. Using a C or U hold to support her breast while applying pressure with the thumb and fingers pulling back toward the chest to help the nipple to protrude when latching may also be effective. Checking for effective positioning and trying different positions to maintain the deepest latches possible is important. If these methods have not proven successful, the preterm infant breastfeeding on a flat or inverted nipple may require the use of a nipple shield to the mother's breast under the supervision of a lactation consultant. Making sure to get the right size nipple shield is essential to maintaining adequate milk supply and allowing the preterm infant to gain as much milk from the feed as possible by accessing as many of the ducts as possible. A thin nipple shield may be applied to the breast to help the infant latch. Mothers should be counseling on the pros and cons of breast shields before they're introduced, such as decreased milk supply, require continued pumping to keep the milk supply up, lead to poor breast drainage resulting in increased risks for mastitis, and requiring the shield to be sterilized every 24 hours. All mothers should be counseled and supported on how to wean from the shield once breastfeeding is better established. Given some of the challenges that preterm infants face, it may take some time to achieve breastfeeding success. It will often take many attempts and increased maturity to obtain and sustain effective latching. Initially, the preterm baby will be fed every 2 to 3 hours on schedule and will eventually move on to on-demand feeds once they mature enough to demonstrate hunger cues such as rooting, waking from sleep, and hand-to-mouth and crying. Because preterm infants spend less time in alert states and more time in transitional and active sleep states, feeding the preterm infant in a quiet alert state is optimal, rather than waking them to feed whenever possible. Timing feeds according to when the infant is most responsive enhances feeding success. It's better to assist the preterm infant to come to an alert state rather than wake them, which is known to have less success at feedings. Because it takes time for preterm infants to organize their suck, swallow, and breath, it's optimal to allow them to suck on the breast after a feed, even if it's non-nutritive, to help them gradually increase their sucking vigor and allow for more milk expression. As the preterm infant is still learning to breastfeed, we can also consider other methods of supplementation with breast milk by spoon, dropper, syringe, cup, and even a supplemental nursing system, which will allow supplementation to happen at the same time as the feed, encouraging milk production. Pumping is important to keep the milk production moving until breastfeeding is well established. If the nipples continue to be flat or inverted, continued use of the pump or nipple extractor or nipple shield that has proven effective is essential until the infant demonstrates good latching ability without such interventions. A good latch should demonstrate the infant's mouth is wide open, holding most of the areola in the mouth, the nose should not touch the breast, and the baby should be looking up a bit at the mother as they are tummy to tummy. Parents of preterm infants need a lot of support by healthcare staff and community resources. Attempting to breastfeed a preterm infant with inverted or flat nipples poses many challenges. But by using our knowledge of the challenges that preterm infants face, feeding on a breast with inverted or flat nipples, identifying cues that can suggest a challenge, judging and deciding on helpful interventions, and evaluating the care of this dyad to make sure it's optimal as you go are essential parts of addressing the priority to feed the baby, move the milk, and help the dyad learn to breastfeed. Thank you so much for your time.